Ladies and gentlemen, please welcome to the stage President and CEO of the California Primary Care Association, Carmela Castellano Garcia.
Good morning, everybody. Welcome to CPCA's annual conference, Building Tomorrow, the Next Era in Community Health. I am so happy to be here this morning. You know, it's hard to believe that next year will be the 25th anniversary of our amazing association. And as many of you know, last year marked my own 20th anniversary as CEO of CPCA. And I've had the time, thank you. I've had the time and opportunity to reflect on my time here as leader of this organization and leader of the Community Health Center movement in California. So if you will indulge me, I want to share with you a story. I want to share with you my story, why I've chosen this path, and why working with you all has been such a driving force in my life. I grew up in San Jose, California. That town made me who I am today. My father, Alcario, was from Artesia, New Mexico. He was a farm worker in his youth, and he worked as a grocery clerk at Safeway. My mother was an executive secretary at San Jose City College for decades. My parents were very in tune with the social justice issues of the day. In fact, my parents were advocates. One of the earliest members of advocacy that I have is my parents pushing my elementary school, which had an all-white faculty, to diversify and hire minority teachers. I remember my dad not only complaining about the negative coverage of Latinos in the San Jose Mercury News, but also showing up at community forums to advocate with the newspaper's leadership that they needed to hire a Latino to be on the editorial board. My mom was a tireless advocate for Latinos at San Jose City College, where she worked. She founded both the Latino Education Association and the Latina Leadership Network. These were entities created to empower and support the college's Latino students and women. Now, these are just a few examples of the type of leadership and influence that my parents exhibited. And as a young girl and as a teenager, I noticed. Through them, I learned the importance of standing up for what you believe in and giving back to your community. Now, another gift I received from my parents, besides a homeschooling and advocacy, was a profound love and respect for my culture. This was instilled in me during the 10 years I spent along with my sister as a Mexican folklorico dancer, including spending my high school years as a professional dancer with Los Lupeños de San Jose. Now, how many folklorico dancers are there in the house? I know you're out there. There always are. You know what? We're all over the place. And there's a few things I need to tell you about folklorico dancers. We are fiercely proud of our heritage and culture because we've been exposed to some of the most beautiful aspects of Mexican culture and tradition, and we have flourished by sharing that with the world. And I thank my parents from the bottom of my heart for giving me the gift of folklorico. Now, many of you know that I now perform with my husband's Chicano oldies band, Cubo, singing and dancing, sharing my culture. Through Cubo, I'm reliving some of the most wonderful memories of my childhood and teenage years, and for that, I am very thankful to my husband. Now, I say my hometown helped make me who I am today because growing up in San Jose, California, exposed me to the profound inequities embedded in our educational system. And this fanned my social justice flame. You see, my hometown had two public education systems. One on the west side where I grew up, which was predominantly white and had many of the top public schools, and another school system on the east side, which was predominantly minority and Latino, and where the kids were not being prepared for college. The boy I liked when I was a freshman in high school, well, he's now my husband, Angel Garcia, he was from Overfelt High School on the other side of the tracks, which happens to be where all the folklorico dancers came from. And he came to practice one day. That's where I first saw Angel. He was wearing baggy khakis, a muscle t-shirt, and a beanie, and let me tell you, it was love at first sight. But one of the most poignant memories I have as a young lady a young girl, really, is being a teenager and taking the bus across town to see Angel at his high school. And I remember that school looking like a fortress. There was fencing, metal gates, security guards. I asked the students out in the parking lot about AP courses and college prep, and they didn't know what I was talking about. And then Angel told me they were being bused to vocational schools to receive training for careers as janitors, woodworkers, and dry cleaners. When I went back to my country club high school the next day on the other side of town, I saw the world differently. I woke up to realize the very significant gift my parents had given me by raising me in West San Jose, a high-quality education, the best you could get in the city's public schools. Comparing these two schools and what was available to students in each, and the huge difference, it moved something within me. And I became determined to take advantage of my college prep public education. In fact, I decided to become an attorney so that one day I could come back to San Jose and do something about the situation. Because after all, as I learned from my parents, if you don't like something, don't just complain about it, do something about it. So when the Lee High School counselor told me not to bother with UC Berkeley because I belonged at San Jose State, it didn't feel right, but I only applied to San Jose State. But within a week of starting there, I knew the counselor was wrong, and I immediately set about doing what was necessary to secure my transfer to UC Berkeley, secretly meeting with the recruiter and putting my plan into action. And in fact, one of my greatest girl power moments was the night I announced, as a surprise to my father, that I was going to transfer to UC Berkeley, and I was going to live in the dorms, and I was going to pay for it with the wages from my 2 summer jobs and my scholarships. He was speechless. And then when I got into Yale, which I intended to finance by student loans, I made a similar announcement, and he actually tried to talk me out of it. But it wasn't his decision. And besides, my mom told me to go to whatever law school I wanted. So when it came time for law school, yes, I chose Yale, and I was thrilled to be there. You know, but immediately I found out, and much to my dismay, that I was the only Mexican-American woman in the class of 1991 at Yale Law School. And the more people I met, the more I realized that I was one of very few students who had transferred from a public school. I don't recall ever meeting another person who had 2 parents who didn't go to college. And yes, I was there with Supreme Court nominee Brett Kavanaugh, and in fact, our Health and Human Service Secretary Alex Azar was in my class. You know, but Van Jones of CNN was there too, and that's a story for another time. But the bottom line is, I knew that I was there with the future leaders in law and policy for America. And when I graduated, I was so fortunate to end up at the Law Office of Public Advocates in San Francisco, where they believe in their young attorneys, and they believe in me. And this is where I want to reflect on what has happened to me over the course of my 27-year career since graduating from Yale. Because what I have realized is that community health center leaders have been a driving force behind everything significant that I have done over the course of my entire career. I ended up forming the Latino Coalition for a Healthy California out of Public Advocates because within a week of arriving, I went to the founding partner, Bob Gnazdel, a Yale alum, and I told him my truth, that even though I was so grateful to be at Public Advocates, that the whole reason I went to law school was because I wanted to improve conditions for Latinos. And if it was at all possible, could I have a project that would allow me to impact my community? At the time, President Clinton was introducing healthcare reform, and there was no Latino presence in healthcare policy in the state of California. And they asked me, do you want to address Latino health access? Well, I said, sure. Now, I didn't know anything about Latino health access, but hey, they had a list. They had a list of prominent Latino leaders that I needed to talk to get on the project. And at the top of that list was Costello de la Rocha, CEO of Altamed Health Services, Jane Garcia, CEO of La Clínica de la Raza, Joel Garcia, ultimately at Tiburcio Vasquez Health Center, and Irma Cota ended up at North County Medical Services. All of these individuals were either founding or early board members of the Latino Coalition. In fact, it was Costello who came up with the name Latino Coalition for a Healthy California. And years later, 3 of the 4 would become chair of the board of CPCA, Jane, Hoel, and Irma, and play instrumental roles in my ongoing leadership development. It was through these leaders that I came to understand community health centers as a movement, how community health centers stand for more than health care, how they are grounded in community needs and serve as a voice for our patients who too often lack access to power. I also learned very early on that advocating for healthcare access for Latinos was more powerful when joining forces with other ethnic organizations and advocating on behalf of the safety net and California's diverse communities as a whole. In fact, it was Sherry Hirota, CEO of Asian Health Services, who strongly asserted, as only Sherry can, that the Latino Coalition would be in a much better position to advocate on the issue of language access if we worked together with the Asian community and other ethnic groups. Now, this led to both my spearheading the formation of the California Pan-Ethnic Health Network, or CPEN, out of Public Advocates, as well as several years of playing a leadership role on the issue of language access with Sherry Hirota by my side. No wonder we created a national model for cultural and linguistic competence standards. With Sherry Hirota by your side, anything is possible. That's true. That's so true. I am so thankful to all the community health center leaders who have demonstrated the strength of broader coalitions and unity, ultimately leading me to where I am now, leading the best PCA in the nation. And by working, yes, we are. And by working to advance community health centers, I achieve both my personal driving passion to benefit the Latino community and have played a role in bringing expanded healthcare access to all Californians. And over the past 21 years, I have been so fortunate to have worked with 20 amazing board chairs at CPCA. Each has played a critical leadership role for the community health center movement, and each of them has supported me personally in whatever personal challenge I may have faced. And personally, my journey hasn't always been smooth. There were the 3 bouts of non-Hodgkin's lymphoma that Angel has had, including 2 bone marrow transplants. The first was early in my tenure at CPCA when I was still trying to prove myself, and the second transplant was years later when I felt secure in my job, but I didn't know if Angel was going to make it. Oh, and the time my dad won that super lotto, that huge jackpot, and I had to be there for my family. Or becoming the president of the Castano Family Foundation 5 years ago because my mother started dialysis and she needed my help. In everything I have been through, CPCA's leaders have been some of the most compassionate and supportive people I have been fortunate to know. And they have all made me a better leader in their own way, and I will forever be grateful to all of them. I'm so proud of how far community health centers have come since I first walked in the door back in 1997. I mean, we have gone from a $795 million industry to a $5.5 billion industry. That's some amazing growth. Patients served during this time grew from 2.4 million to 6.5 million. It's amazing. The number of health centers has grown to 1,300. You know, but what I'm really proud of is our success under the Affordable Care Act. Opportunity knocked, and California's community clinics and health centers stepped up and took center stage. We have served as a model for the entire country. With the expansion of Medi-Cal in California, the number of health center Medicaid patients has doubled, growing from 1.8 million in 2012 to 3.8 million in 2016. Community health centers were selected as the primary care provider for 54% of the newly enrolled Medicaid beneficiaries. That's what I'm most proud of. People had a choice, and they chose community health centers. And thanks to all of you, California is a leader in expanding healthcare access and is making strides toward healthcare equity. But here's the thing. You know, I look back on my time at Yale, my classmates there. I look at the faces of leadership in Fortune 500 companies, in boardrooms and C-suites. I look at leaders in American politics, leaders of trade associations here in Sacramento. And I see that our patient population is not equitably represented. And if we don't have more women, more people of color, more low-income and rural folks, more public school kids from East San Jose represented in our nation's leadership, then we are destined to fail these very populations. There are many fronts to fight if we are to win this battle, but I believe that one of the most meaningful, one of the most impactful, is the struggle for health equity. I look out at this room today and I see people who have dedicated their lives to this struggle. And I count myself immeasurably fortunate to stand with you in all that you do. Now there's something else I want to share with you, something I'm really excited about. I wanted to tell you my story so that you would understand what it means to me that later this month I will be traveling back to New Haven, Connecticut to receive the Award of Merit from my alma mater, Yale Law School. Past recipients of this award have included Hillary and Bill Clinton, Governor Brown, 3 sitting Supreme Court justices. I mean, I've known this for almost a year, but let me tell you, it is starting to hit me. This is a really big deal. And when I think about this award, the truth is, as far as I'm concerned, I'm not receiving the Yale Award of Merit. We, all of us in this room, leaders within the Community Health Center movement of California, we are all receiving this award. And I couldn't be more honored or delighted to share with you this incredible acknowledgement. Because the fact of the matter is, as my story makes abundantly clear, community health centers have been central to everything significant that I have accomplished that this honor represents. Community health center leaders have been by my side my entire career. We did this together. And I see this award in many ways as not only a recognition of my career accomplishments, but a resounding endorsement for the work that we all do. Justice is something we fight for every day, maybe not in a courtroom, but in our communities. And it means so much for me, for Yale Law School to acknowledge that our work has merit. You know, and in fact, when I was told I was going to receive this award, I literally couldn't believe it. But after I wore over the shock, you know, I want to tell you, Lady Justice, I've always wanted a Lady Justice. I've been inspired by Lady Justice, you know, the one with the sword in the hand, the scale. I've been looking for her for 27 years since I graduated from Yale. I hadn't found my Lady Justice. But when I looked up the award online, much to my surprise, I couldn't believe it. The award is a stained glass Lady Justice made from a replica of a stained glass that adorns the law school at Yale Law School. So, it's all about ultimately justice. And that's where I want to end this. Community health centers are leaders in justice. And for me, it has been truly the most significant honor that I have been able to represent all of you as we achieve that goal. Thank you very much.
Please welcome Sherry Hirota, Chief Executive Officer of Asian Health Services.
Carmela, what great leadership, and with her leadership and with all of you in the room, we know that the California clinics have only success and in our future. So big round of applause again for Carmela. So good morning, everyone. If you could just all stand up, I would really appreciate it. If you haven't had enough caffeine, if you are sort of tired from meetings for a couple of days, please stand up. We want our energy up because I want to tell you that you're going to need all the energy to keep up with the next person I'm going to introduce to you this morning. So thank you. Everybody have a seat. Great. It's my greatest pleasure to introduce to you the incoming Vice Speaker of the House for the National Association of Community Health Centers, Dr. Kim Chang. So for those of you who don't know her, she is a Hawaiian local girl. She also has been at Columbia, University of Hawaii, UCSF, and Harvard. But I think her greatest education has been her 16 years at the University of Asian Health Services. As all of you know, the clinics is a great place to really build and round out your education. She led a brand new clinic as a clinic director, productivity, recruitment, HR, you know the drill, all the nuts and bolts. And in all of that, she totally excelled and brought that clinic up to a high performance level. But at the same time, she was watching what she was seeing in the patient base. In her teen clinic, she saw sexually exploited minors and then proceeded to build a program that has garnered national attention to this issue. So I would just say all the Ivy League schools, all the years at Asian Health Services has led her to today, which is a leader and ambassadors of community health. Please help me welcome Dr. Kim Chang.
Thank you, everyone, and thank you, Carmela and Sherry. I want to echo what Carmela said. With Sherry Hirota by your side, anything is possible. So can you stand here so I can get through this speech? So I actually think this is a test to make me speak after Carmela and Sherry. Being introduced by Sherry and then watching Carmela and Sherry's career since I've been at Asian Health Services for the past 16 years, I feel like I've truly made it. So thank you. I also feel like I've truly made it because I get to stand up here to address and welcome you, my peers, my colleagues, and my friends, and to honor all of the work that you are doing in your communities. So let me start with this. I believe in community health centers. I love community health centers. What we do every day, what we've been doing for decades, for half a century for some of you, is to be a beacon of hope, care, opportunity for our patients and communities who are often left at the margins of society. We are engines of social and economic mobility. We get outcomes and we deliver results. And we don't stop at providing excellent medical care, but we continuously strive to change the policies, systems, and conditions that cause harm to our patients and communities. And we don't stop there. Not only do we fight these upstream policies and systems that cause harm, we empower, engage, and build capacity of our patients to rise up and do that as well. As we all know, our bosses are our patients. We are accountable to them first and foremost. I believe in community health centers. We can and are changing the world. Let me give you an example. Sherry already mentioned it, the example of the commercially sexually exploited children that we were seeing at Asian Health Services, and the issue of human trafficking overall. Sherry talks about this issue as if it's me doing it, but actually it's not. It's Asian Health Services and the community health centers overall. We started seeing these patients before I even started at Asian Health Services in 2002. Asian Health Services in 1996 started a youth program to respond to an uptick in teenage pregnancies in the Asian Pacific Islander community in Alameda County. Once the kids started learning about their health, they wanted services. So in the year 2000, Sherry said, okay, go ahead and start, this pilot teen clinic, and it can be at night and no adults are around, and go do your thing. This is before I started. And so they started seeing these patients very early on, right at the beginning. The teen clinic started seeing these commercially sexually exploited children. Now, mind you, at that time, the federal legislation defining commercially sexually exploited children as victims of human trafficking or sex trafficking was just passed that same year, in the year 2000. We didn't know that they had these protections because the federal policy hadn't affected the state policy yet. So at that time, my colleagues in the teen clinic looked around and said, well, what are we going to do? What are we going to do for these kids? They can't get services unless they've been arrested and prosecuted for solicitation. And we weren't about to turn them over to be arrested. So my colleague, Jennifer Lee, who now works at APCHO, the Association of Asian Pacific Community Health Organizations, created a curriculum, a youth development curriculum for these patients, for these community members. And Sherry won an award that year, I think it was 2004, from the California Wellness Foundation. She got $25,000. And I was like, wow, she's making the money. But you know what she did? She turned around and she took that money and she seed funded this curriculum that Jennifer Lee had created for her Masters of Public Health program at San Francisco State. And so she created this program for commercially sexually exploited youth that's still going on, that she still supports. So that was in 2004. With Sherry Hirota by your side, anything is possible. So that we don't stop there. So I started seeing these patients, and I just did my doctor thing. And we knew that there was still more to be done. The patients were still being arrested. And my colleague here at this front table, Julia Liao, she said, hey, you need to get more awareness around this issue. I have this reporter from the New York Times. And Julia put us in touch, and they did a whole feature about Asian health services and Bante Sray. And that launched a lot of other, and opened up a lot of other doors for us to have a seat at the table to say, let's not arrest these kids, let's create funding streams and resources for them, and let's treat them as patients, as people who need care and help. So that was Julia. And then we didn't stop there. My colleague here next to Julia in the red shirt, Dr. Tu Quach, she says, well, you really need to have the evidence. You really need to have the evidence. And she does research. She's an epidemiologist. And she led a research project at our health center showing that if we address this issue in the healthcare setting, some of these patients will disclose. That's not the goal, but some of them will disclose. But really, that if we address this issue, we could reach out to these very underserved and marginalized patients and get them the care and resources that they need and help. So that was Dr. Quach at Asian Health Services. So I bring this up because it's not about any one person. It's about all of us and the team that we have at the health centers. So that's just one example. That's just one example. I look at our agenda. Where's our agenda? I look at our agenda today, and for today and tomorrow, and I'm so excited to see the topics and the issues being addressed. Immigration, public charge, substance use disorders, disability, our response to natural disasters, dental integration, workforce development, integrated models of pediatric and geriatrics. And I'm thrilled and my heart is full. I love community health centers. We shape policies and practices to ensure a better and healthier future for our patients and communities. We fight for a seat at the table. We make sure our patients' voices are heard at the table, and we make damn sure these voices have influence and impact. And even as we look to secure our future as the premier primary healthcare delivery system in the nation, we honor our past, and we never forget, and we always remember, and we hold at our center our deep roots and tradition of patient-centered care and advocacy. With all of this in mind and in heart, I welcome you and know we will have an incredible 2 days together. Let me end with this. I believe in community health centers, and what this really means is that I believe in us. Thank you, and welcome.
Please welcome to the stage California Primary Care Association's 2017-18 Board Chair, Scott McFarland.
Thank you. It's a pleasure to be here today. It's my pleasure to be here this morning to introduce the morning's keynote speaker. Naomi Fuchs is the Chief Executive Officer of Santa Rosa Community Health Center, the North Bay's largest health center network. Since taking the helm in 2001, Santa Rosa Community Health has grown from serving 5,000 patients in one location to many locations, serving 50,000 at 9 different campuses. Ms. Fuchs also served as the 2016-17 CPCA Board Chair, but was unable to join us last year due to the devastating wildfires that hit Santa Rosa and the surrounding areas. She showed tremendous leadership at that time at her site and in her local community, an example for all of us, especially me as incoming board chair. She left very big shoes for me to fill, and I don't walk well on high heels. True to her nature, Ms. Fuchs also took on leadership of making sure that lessons learned during the tragedy in her community translated to statewide change to make sure that when a disaster strikes health centers, we are better positioned to address the needs of the communities. Working in tandem with the Redwood Community Health Coalition and California Health Plus advocates, they developed legislation that did just that. I am happy to report that the legislation, Assembly Bill 2576, was signed by Governor Brown last week, a huge victory for all health centers. This morning, Ms. Fuchs will discuss her lessons learned as the firestorms of 2017 tested health center leadership in many new ways. While struggling with the emotional and physical devastation around them, health centers stood strong to support their staff, their patients, and their communities. We will hear directly from her on the path she took and the lessons learned in the last year of rebuilding. Please join me in welcoming Naomi Fuchs, CEO of Santa Rosa Community Health Center.
Sunday, October 8th, 2017, 9:30 p.m. I wanted to get a good night's sleep that night, rest up for a busy week ahead. I'd actually been having a hard time sleeping, and so I consciously put my phone downstairs off. You know, no screens before bedtime, right? 4 a.m. I was awakened by the gentle but very insistent voice of my husband. Naomi, you have to get up. Santa Rosa's on fire and the Vista Health Center may have burned. Threw on my clothes and checked my phone. My phone had blown up, 20 texts, a million emails. I knew it was bad. I went online to see the extent of the fires. Where were they burning? What had been destroyed? It really was horrific. The whole city was on fire. The hotel next to our health center had burned to the ground already, so I wasn't hopeful for our Vista Health Center. I had to go see what was going on. Had Vista burned? What about our other sites? We jumped in the car. We headed for town. We live about 25 minutes away. But when we reached that first intersection, there were literally thousands of cars at 4 in the morning fleeing Santa Rosa. The line at the gas station went on for half a mile. It was impossible to get through. It looked like Armageddon. I went home. I started contacting key staff. How was everyone? Where was everyone? What's the plan? 11 a.m. I was able to reach our safety officer and a few others and we agreed to meet at our Lombardi campus a few miles from the active fires. Really, what happened the rest of that day is kind of a blur. I remember trying to get supplies and equipment to the shelters, setting up a group text to reach all of our leadership, working with our safety officer to assess the condition of each health center. We had 11 sites. And a friend of the family texted me. He'd gotten up to the Vista campus on his motorcycle. It was still standing. We were so relieved, but knew there was serious damage. Later that day, my husband was able to get past the police. The National Guard hadn't yet arrived, and inside the building, and confirmed that the sprinklers had saved the building from burning to the ground. The roof had burned, windows were blown out, interior rooms had burned. There was smoke and soot everywhere and melted insulation that just dripped throughout the building. And of course, the whole building had flooded for more than 24 hours of sprinklers running. When he opened the doors, the water just poured out. It came running down the stairs and out the front door. We knew it was bad. We didn't know how bad. But by 2 p.m., we knew that 24,000 patients and 180 employees had lost their medical home. The cell phones were working, and our internet was up off and on, so we sent texts and Facebook messages telling everyone who was able to meet at our Lombardi campus the next day to see patients and figure out our next steps. 6 p.m. Sitting on the floor in the conference room, exhausted, overwhelmed, we had the first of what would be many all-hands leadership conference calls. We agreed to meet at 8 a.m. in the morning and do what we could to take care of people. Lisa Ward, our chief medical officer, couldn't come in on Monday. Her home was fine, but the freeway was closed. So we spoke by phone that night and made a plan for how to organize the work and the people. Tuesday, October 10th. Now the fires continued to expand across the city. There was 0% containment. 7 a.m., a few of us arrive at our Lombardi campus to organize the work that lay ahead of us. Facilities staff had already set up a conference room as our incident command center. 8 a.m., first all-hands in-person meeting for leadership. We had listed on the whiteboard all the key staff, their area of responsibility, and their cell phone numbers. 9 a.m., the staff start to arrive. People were really scared. They were concerned. They didn't know if they were going to have jobs. Many had been evacuated and were staying with family or friends. There was lots of hugging and lots of crying. Now, our IT staff went to Vista to see if they could retrieve the servers. It was over 100 degrees in the building. Everything was covered in ash and soaked from the sprinklers. When they arrived back at the command center, they were covered in black soot, but they had recovered the servers. At 10 a.m., we opened the Lombardi Clinic to walk-ins. Everyone was welcome. We used paper charts. Our EHR had not been restored and would take many days for that to happen. We opened our Lombardi pharmacy and provided more prescriptions in that one day than we usually do in a week. Everyone had evacuated without their medications. We also assigned physicians, nurse practitioners, nurses, and support staff at the shelters providing medical care. So it turns out that the Red Cross does not actually provide medical care. They provide lots of food, blankets and cots, organize all the donations, and they provide first aid. Nor does our county Department of Health provide direct medical care. It fell to the community clinicians to step in. And since Vista wasn't open, we actually had quite a few clinicians to take care of people. One of our Vista clinicians led the effort to organize the medical services, another to organize the volunteers that wanted to help. They organized medications from our pharmacies, assigned bed numbers to those who needed medical supervision, created a paper charting system, 24/7 coverage, and a process for handing patients off at shift changes. Now, several nursing homes had been evacuated to these shelters. These people were fragile and needed medical care. Many were on oxygen. And that afternoon, I got a call from the shelters. 20 patients were on oxygen, and their tanks would run out in 4 hours. Where could we get replacements or concentrators? I really worried about this becoming a medical emergency. 2 of our 3 hospitals in Santa Rosa had been evacuated Sunday night. I called the CEO of the one open hospital to see if they could help. I said, if we don't get oxygen soon, all of these people will need to be transported to your hospital. He directed me to someone who could help, and later I learned that his house had burned, and he'd been at the hospital since 2 a.m. on Monday. 8 p.m. We'd seen every patient that walked in, set up a call center in a conference room, and started calling patients who either had appointments at Vista or were medically at risk. Our mental health staff were calling patients and providing over-the-phone support to their most vulnerable patients. We'd set up a mini hospital unit in the shelters, and we were starting to figure out how to put providers and staff into our other much smaller sites. We set up a system for all-hands leadership meetings, either in person or by phone, 3 times a day, plus an early morning call to update on fire conditions. Where were the evacuations? How bad was the smoke? Which clinics would be open? These calls continued for 2 weeks as conditions were constantly changing. We have 500 employees, and there were 500 very unique emotional responses to the disaster. For some, their adrenaline kicked in and they were focused and ready to work on anything we asked. For others, they were in shock and couldn't come in. Most experienced all kinds of strong feelings all day, all week, and truly for many, many months. Some people want to process their feelings. Others don't ask. As leaders of the organization, it was our job to make space for everyone's reactions and support people through it all. Now, this was my personal experience of the first 2 days, and every person had their own unique experience. For many, many people, that included driving through walls of flame, fleeing from their homes in the middle of the night, and for some, losing their home and all their possessions. I'd like to share with you a few other voices from our health center about those first few days.
I didn't know what to do. I didn't know what to grab. The only thing I thought to bring was a pile of blankets because I thought we'd be spending the night in the car. The wind was just churning chaos.
La lumbrera estaba a una calle nada más, un bloque. Todos nos asustamos.
It just created an inferno in this valley that took off.
And we started realizing, wow, this is much bigger than we had thought.
By about 10 in the morning, we had heard that the health center here had been badly burned. We have a play structure out in the front of the health center. There was a tube slide that started to catch on fire and we believe acted like a blowtorch, shooting flames up the side of the building, catching the roof on fire. The Vista campus was our largest health center. This facility served half of our patients.
Our patients are the people in this county who are laborers, who work in the service industry. They're living from paycheck to paycheck. One paycheck gone could mean homelessness for the majority of our patients.
How are you feeling now? Do you feel like your breathing is still different?
I'm weak and all this smoke wouldn't help.
180 employees worked here to take care of all of those patients. And now that it's gone, it's a tremendous loss to this community. We have to rebuild. We have to come back and be here for them.
The morning of this event, I was in my car, driving I didn't know where, and I got a text message, and it was from Dr. Patricia Kulaviak, and it said, "What are we doing? Let me know what needs to happen." She didn't know at that time that her house had burnt down.
If Santa Rosa is going up in flames, there's going to be a lot of people with problems that are going to need help. And so I started thinking right away, I needed to go back.
We have 24,000 patients who rely on this as their medical home where they get their primary care, and we're here for them. That's our mission, and we'll do that no matter what.
Our patients come in with different types of experiences and traumas, and we try to relate, have empathy, and understand what they're feeling.
And what people need right now is to know that they're not alone, that there's support, that we're going to be here for them no matter what.
The society is not set up to benefit them. So we try and set this place up to make up for some of those disparities that exist out in the community.
As a patient, I respect her very much and one of the best doctors.
Thank you, Jose. It's been a hard couple months.
Gracias, doctora.
What's important is making sure that the folks who are really struggling, the same people who were really struggling before the fire happened, are being cared for and held and nurtured.
I'll hug you all day.
I think we're very early on in this recovery phase. I think we still have a couple of years in this rebuild, not only physically, but rebuilding of ourselves as we move forward.
Now the hard work starts, but the attention is going away. It's actually right now that people need that support to take on the marathon of recovering, because it's a marathon. It really is.
So, I know that many of you faced your own disasters this year. Fires, mudslides, floods. You have your own traumatic experiences, and truly, my heart goes out to you. We know there'll be more disasters and other emergencies, so I am going to walk you through a little snapshot of how we responded and the lessons we learned. The facts of the fire: 5,000 homes were burned, 50,000 people evacuated. There were 35 evacuation shelters, 2 hospitals closed, and Sutter and Kaiser outpatient was closed for weeks as well. At our health center, as it's been mentioned, that burned, it took care of 24,000 patients, 180 employees. It was 56 exam rooms and 50% of our revenue, a 42,000 square foot building. So what did we do? How did we take care of all these patients and all of these employees? I'll share with you now the 3 phases of disaster recovery: response, recovery, and rebuilding. In the first few days, the fires were continuing throughout the county, changing direction, changing hotspots. We never knew the full scope of the disaster. Our first priority was, where's all the staff? Are they safe? Can they come to work? We needed to use as many different communication modalities to try to reach people. We activated our phone tree with calls and texts. We reached out on Facebook and sent emails when our email was up, which took several days. In the end, it took us 4 days to find 100% of our employees. Unfortunately, our phone lists were not completely up to date, and people were hard to reach. We also needed to establish all of the roles and responsibilities in the command center. There were shelter services. Who'd be responsible for organizing medical care in the shelters? Who'd be responsible for organizing all of the volunteers that wanted to help? Staff deployment was huge. Who was available to work? Where would they work? The first couple of days, we just sent all the MAs to one conference room and said, you'll be assigned a provider and a health center momentarily, once we know which providers were available to work. Provider deployment was critical. Who was available to work and where was there space for that provider to see patients? Which health centers would be open that day based on smoke and evacuation needs? There's logistics and supplies. We needed masks. We needed oxygen and medical supplies. We needed more trash cans in our command center now that we had 180 people working there that hadn't been there before. We needed IT, of course. We had to get the phones back up and email up and our EHR working. Communication systems needed to be established for staff, patients, and media. Our finance team was responsible for assessing the cost of the disaster, the impact on revenue, and starting that long process of working with insurance. And we needed someone to work closely with our county of Office Emergency Services, and don't forget food. We fed everyone breakfast and lunch for 2 weeks. This not only provided much needed nourishment as we worked 12 to 14-hour days, but really it provided a time for people to come together and share what was going on, talk to people they haven't maybe seen all day. It helped to create community and support. Little by little, we started thinking about recovery planning. And it worked out that it turns out that the people who are in the command center are not really the best ones to be doing the planning. They need to work off-site where they're not bombarded by the minute-to-minute activities of the response team. In this command center room, the walls were lined with flip chart paper for every area of responsibility. We used it for huddles where people could convene and say, well, what's going on with this and how is that going? We also used it as a place for people to come and write down the issues so that they weren't looking for someone to tell all their problems to. Now, we also had to set up communications. We started with the internal communications. As I mentioned, we set up communications check-ins 3 times a day in that first 2 weeks. My motto was to communicate at the rate of change. We set up a conference line and about 30 people joined in person or online to check in, provide a status update, and understand needs in the field and make plans for next steps. Since the fires continued to rage for weeks, we often had to shift what sites were open, who's been evacuated, and where staff should go to work. Now, not all of the role assignments made in that first day worked out. If it wasn't a good fit, we had to make an immediate change. There really wasn't time for a PIP. Also, 2 of our key leaders were unable to come to work that first week. So we had promoted 2 staff people temporarily to step up into leadership roles. Now, we also needed to reach our patients. The first thing we did was send up this central call center. We converted one of the conference rooms to the call center with nurses and physicians on site. Our IT support vendor brought in laptops and phones. We set up folding tables and printers. Now, we didn't have a centralized call center before the fires, and I really don't recommend trying to convert to a centralized call center in 24 hours. But that's what we had to do. Having clinical staff in the call center was critical to prioritizing patients, assessing clinical issues, and responding to patient needs on the phone. We did a lot of phone medicine in those first weeks and even months. We used as many channels as possible to reach patients and the community, including Facebook, radio, text, email, and phones. we also need to deal with the media. We assigned a single point of contact for all media, and we had a backup. This person coordinated newspaper, government relations, and any foundation requests for information. Telling our story really was critical. We sent information to local radio stations regularly and sent press releases as frequently as key operations changed. They were our conduit to patients and community to let them know what was going on. We also developed a white paper to send to anyone who needed information, including the county, HRSA, potential donors, and foundations. It included a brief description of the event, the impact on the community and the health center, the potential costs to the health center, the plan for recovery as it developed, and our needs, financial as well as supplies, equipment, and resources. So many people wanted to help, but they didn't know how. And often when people asked, I didn't always have a good answer. It's important to take the time to articulate your needs to government, funders, colleagues, and friends. We designated one person to field all of the offers of help, whether it was 5 pounds of coffee or 1,000 N95 masks. And of course, we wanted the voice of our staff and patients to be heard, so we encouraged people to tell their stories directly to the media as well. So how did we provide care in all of this? The demand for care was actually quite high in those first few weeks. That first day, Tuesday, we only saw 350 patients, about 22% of our usual visits. But by the end of the second week, we were already seeing about 75% of our regular volume. We saw everyone who walked in the door, but we also reached out to scheduled patients and let them know we were open. Our first priority were patients who walked in our doors. We were seeing mostly respiratory illness, aches and pains, early distress, and of course exacerbation of mental health issues. Second priority were patients whose lack of medication would harm them or worsen their illness. People in our substance use disorder program, chronic pain patients who needed their opioid prescriptions. Our third priority were patients whose lack of medicine would impair treatment, such as our HIV patients, Hep C, and diabetic patients. Also critically important were our OB patients, particularly those in their third trimester. Now, people who were undocumented did not want to go to the shelters, particularly after the National Guard arrived. They fled to the beaches. We sent outreach staff and nurses to those encampments to assess medical needs, provide information about where to get help, and see who needed prescriptions filled, and try to connect people to care. We started to set up systems for alternative ways to care for patients, such as phone medicine. We actually created a telephone visit template in our EHR for charting telephone visits, as if it were a regular visit for both medical and mental health services. And we are still hoping that we'll be able to get billed for these services, given the new legislation about providing care in an emergency that was just signed into law, thanks to the great team at CPCA. Also critical to care during this time was our pharmacy. Patients evacuated urgently without their prescriptions and without their medications. Community pharmacies were closed initially and very short-staffed thereafter. Our pharmacy was a key partner to our entire community. Our usual fill rate is about 2,000 prescriptions a week. On day 3 of the fire, we filled 3,000 prescriptions in one day. Now, with Vista closed, we had about 30 FTE of providers that no longer had a place to practice. We decided to redeploy some of these clinicians to new types of clinical roles. They went to the shelters. They worked in the call center, answering clinical questions and prioritizing patients. We had teams of providers managing EHR inboxes for all clinicians. They were completing prescription refills as our nurses were needed elsewhere and doing phone visits, as I mentioned. And then we had the shelter medicine. On the first day of the fire, we got 2 calls to action. One from the public health officer telling us there was a mass evacuation, and another from the principal of a high school where we had a school-based clinic asking for help to manage the care in that evacuation site. On day 1, we deployed 4 physicians, residents, and our director of nursing to the main shelter where hundreds of skilled nursing patients were being taken. There were 250 care-dependent elders that had been transferred to the high school gym, some in beds, some in wheelchairs, some with walkers or with care attendants. 20 of them were oxygen dependent, and many were disoriented or suffered from dementia. Our providers built from scratch a functioning hospital-type unit in that gym. They operated 24/7, and that lasted for over 4 weeks until patients returned to their care places. They created paper medical records and medication logs. For the people who needed regular medical care, numbered their beds so that they could be followed. They had a big whiteboard with bed numbers and key patient issues. They developed a rounding structure and a sign-out process. In all, Santa Rosa Community Health support staff, family medicine physicians and residents, nurse practitioners, nurses, psychologists, and psychiatrists all were deployed to 6 shelters across the community. Now, our medical directors were receiving hundreds of calls, texts, and emails from providers outside the county and the area who wanted to come help. This was taking a lot of time, and there was no central coordination. Now, the partner of one of our physician leaders quickly developed a website using Sign Up Genius, that same website where you coordinate a potluck, where we could list all of the shifts and resources needed, physicians, nurses, mental health providers, and where we could direct volunteers to go sign up for an open shift. This was a brilliant and simple solution that made it possible to connect people who wanted to help to the needs in the shelters. Now, I've mentioned that we have residents. Santa Rosa Community Health has a partnership with Sutter Family Practice Residency, where 36 family practice residents have their continuity clinical experience and their training. Their continuity practice was at the Vista Health Center. Now, we've had this partnership for 10 years, and we're deeply committed to the education of clinicians in community medicine. When the fire hit, we needed to figure out what to do to maintain the education of the residents. A break in continuity for a resident can be disastrous. The residents and faculty were really worried that if they missed too much clinic time, the residents wouldn't be able to graduate. Now, even though the family practice residency is a partnership with Sutter, we were very clear. The residents are not separate from the health center. They are part of our family. The residency leadership briefly considered trying to move their clinical practices to other health centers in the area, but that had other major challenges. We all made the agreement to make it work at Santa Rosa Community Health. Operational leaders jumped in to work on a plan to schedule residents in full clinic schedules and to reduce their didactic education time. This meant that residents had to work evenings and weekends more than they usually did. Faculty providers did not have any clinics, and nor did their patients have access to them. All other providers worked fewer clinical shifts so the residents could work their expected capacity. Now, this did result in the loss of patient access, as well as in revenue by not having our most productive providers working in our very limited exam room space. But we felt it was the right decision to ensure that our residents would graduate. People were flexible and understanding about the changes in locations, shifts, schedules, but the change was also really hard on people. Supporting staff throughout the weeks of the disaster was a high priority. We had volunteer massage therapists come in and give massages to staff. People brought food and treats. In addition to meals, we created social hours and support groups. We started every meeting with a check-in and let people take as long as they needed to share. We were flexible about time off, as 20 staff we now knew had lost their homes to fire. Hundreds had been evacuated. Others were losing their rental home when the owner lost their home in the fire. And some of our staff spouses had lost their jobs. We had a gathering at Vista once we were allowed to get back on the site to grieve the loss, share remembrances, and just be together. We established supplemental benefits for people who evacuated or lost homes. We let people cash out PTO if needed, and we paid everyone their regular hours for the first week, regardless of if they were able to come to work or not. We understood clearly we need to support the staff through personal and vicarious trauma, and we still do. Now, by the third week, we started to move into the recovery phase. The fires are still active, but they're starting to be contained, and help was arriving in many different ways. Now, our command center had been using a huge room at the Lombardi campus, and it was needed for staff and patients. So command center staff started to be in the way. We needed to move off-site. Our administrative offices are located across the street from Vista, and while not burned, they were closed due to smoke and proximity to the fires. Remarkably, our IT support vendor, really an amazing partner throughout the fires, offered to have more than 20 administrative staff move into extra space that they had in their offices. They provided us phones, desks, conference rooms, and a kitchen, and most importantly, they made us feel welcome. It was very generous and critical for us to keep doing the work that was needed. And of course, vans from our neighboring clinics started to arrive. Thanks to our wonderful sister health centers, we received mobile clinics from Avenal Community Health Center, Tri-City Health Center, Tiburcio Vasquez Health Center, Washington Hospital, and Sonoma Valley Community Health Center. And we began in earnest to create a plan for the future, short, medium, and long term. In this photo, you see Dr. Ward, our Chief Medical Officer, figuring out how many providers can go where and at what times, and how many support staff they will need, and who will need to move where. It's on a whiteboard because it's still changing every week. We established a 3-phase recovery plan. As the reality of the extent of the disaster was unfolding, we began the process for this long-term recovery plan. Phase 1, officially called the response period, but I lovingly called it the high-density plan. This is when we moved everyone that was not a clinical provider out of every health center we had and transformed all available space into exam rooms. We converted conference rooms into waiting rooms, administrative offices into mental health offices, and mental health offices into exam rooms. People worked many more nights and weekends than they had previously. Each health center site took on additional providers and added shifts. Now, our Lombardi campus was packed. People were generous and flexible about the constant change, but after a while, it was exhausting. I remember going to an all-staff meeting at the Lombardi campus and talking about how hard it was to have 100 or more new staff people, almost double the staff that are usually there, thrust into their lives. Staff roles are not the same across all sites. There were new bosses, there were new providers. I said to the staff, well, it's kind of like having distant relatives come to live with you unexpectedly. You know their family, you want to make them welcome, but this isn't what you asked for. It isn't what anybody wanted. There are too many people at the dinner table. The kids have to share their bedrooms, and sometimes there are arguments, and you may not actually like everyone that much. And for the Vista staff, you don't necessarily feel welcome in this new location all the time. You wish you were in your own home. You're doing your best, but it's hard. And in the end, we are a work family, and we need to be there for each other. We supported them through that difficult transition as best we could and encouraged everyone to be patient, kind, and understanding. In phase 2, we started to decompress our Lombardi campus and other sites by moving people into temporary locations. In December, only 2 months after the fires, we opened our Fiesta Health Center, which is a collection of 7 clinics in a can and 3 mobile vans, 10 exam rooms in all, located in the parking lot of our dental clinic. This location became the hub for our Ryan White HIV services. But you may be wondering, what are clinics in a can? Clinics in a can are fully equipped medical exam rooms inside of a shipping container. They arrive on a truck, are put into place with a forklift, you open the doors, and voila, an exam room. They are safe, they are durable, they are transportable. We covered the collection of cans and vans with a party tent, thus the name Fiesta. Put portable laptops in each exam room, and we were ready to go. Now, we had already been planning on opening a new health center, and it was under construction. It was delayed a bit due to the fires, but we were able to open this new site, our Dutton campus, with 22 exam rooms and 8 dental chairs in March. This health center absorbed the majority of the VISTA providers and staff. And at first, we thought we were going to need to lease or purchase a modular clinic. We had located an open lot on county land, had drawn up plans for water and septic and footings. It was going to cost $2.5 million to purchase and set up a modular clinic. Fortunately, in the end, we located and leased a medical office suite from Sutter with 19 exam rooms, which became the hub for the residency and faculty practices. Within 4 months, we had our new Fiesta temporary site with 10 exam rooms, Airway, which was the Sutter leased space with 19 exam rooms, our brand new Dutton campus with 22 exam rooms. We had replaced 51 exam rooms out of the 56 that we lost, and we were back to about 96% of our visits prior to the fire. The long-term plan, of course, is to rebuild our Vista campus. You can see on the left what it looked like before the fire, below that after the fire with everything melted and washed away, and that big metal structure with all those framing, that's what it looks like right now. In the end, we had to gut the inside completely and even take down the exterior stucco siding. We have to pretty much start from scratch. And even though the health center was only 7 years old, we decided to redesign the interior based on what we have learned about clinical space and team-based care. And now we're very excited about having a beautiful new health center next summer. A couple more lessons learned. I have to really admit that before the fires, I was definitely one of those CAOs that did not pay much attention to our emergency plan. I was really glad that someone else was taking care of it. I understood it was important, but it seemed so hypothetical. And there were real, immediate needs that had needed attention. I have really learned my lesson. One of the good things we did have in place already was a system for an administrator on call at all times. We published the schedule and cell phone for all of the executives who were on call to all of the leadership staff. And if you were on call, you had with you the briefcase. In that briefcase is the emergency plan, keys to all the buildings, floor plans for all the buildings, lists of staff cell and home phone numbers and home email addresses. We keep those up to date now. In addition to social media to reach people, we set up a call-in line where people could hear and up-to-date information and leave messages about their ability to come to work. We did not have a group texting app like Slack set up. This would have been really helpful, and I would recommend that people look into this as part of their emergency plan. We had not trained people on roles and responsibilities. Of course, that would have been a good idea, and I recommend that as well. Another lesson learned really has to do with flexibility. The roles in your emergency plan may not be the roles you need in your disaster. The people that you have assigned to those roles may not be able to do them. They may not be present. They may have to evacuate or come and go during the disaster. And sometimes the skills you thought people had aren't really the right skills for the job. Need to be flexible and be clear about assignments. And take feedback. If someone says, I can do more, or this isn't the best job for me, listen and adjust quickly. Communication is key. So, what did we learn about communication? Something that we're not all great at, and that's asking for help. Clearly articulating your need, reaching out to partners. We reached out to our colleagues at local hospitals, contacted our partners at foundations, engaged our state senators and congresspeople immediately, as well as federal representatives. And of course, CPCA and all of you, our sister health centers, were incredibly supportive. We sent daily emails to all staff once our email was up, coming from different leaders in the organization. This went on for weeks and months, as did daily conference calls with our leadership team. Resilience. Resilience is critical to the long-term recovery of our organization and our community. We tried lots of different ways of creating connection for our employees, including support groups, employee assistance programs, rituals and celebrations, frequent check-ins, massage and yoga and qigong were offered to all the staff, and we still do that. And when we asked the staff what they wanted, they said social time was the highest priority. Now, our community is still very much in shock. While the land has been cleared and grass has grown over the hillsides to cover the char, we've only just begun to understand this fire. There's those that have lost their homes and those that did not. Those with resources and our patients, those without. There are those that are documented and have access to assistance and those that do not. There are those that care for survivors, and then there are just the survivors. There are so many layers of grief and loss for medical providers who are both experiencing their own loss, some more acutely than others, and those who are caring for patients. Seeing patient after patient who tells the story of their loss is exhausting, especially for healthcare workers who have also experienced and grieved their own losses. A few weeks after the fire at our Vista Remembrance, when I asked one of our medical assistants how she was doing, she started to cry. She said, it's really hard to hear everyone's story of tragedy all day long. She said she just couldn't ask anymore. It was too much. People had different levels of injury and also recover in different ways and in different times. There's actually a somewhat predictable cycle to how people will feel during and after a disaster. When the disaster hits, there's that hero phase. The adrenaline is pumping. Everyone is working together for a common purpose. There's an incredible sense of unity and dedication. Then more waves of emotion hit. People are teary, distressed, distracted, and overwhelmed, easily triggered. And people have rallied as they start to see progress, feel like things can get better. Then another downturn comes as they realize this is a really long haul. We are now at the 1-year anniversary and people are struggling. We've lost several key staff right about at the 6-month post-disaster mark. I call it post-disaster restlessness. I need a change. I can't do this anymore. I want something different for my life. I don't see a future in Sonoma County for me and my family. Many different reasons, but a similar theme. Everyone in our community has experienced trauma to some degree or another. And who is most susceptible to adverse effects of trauma? The people who are most susceptible are those who are already vulnerable, already under a heavy stress load, low-wage earners, immigrants, people experiencing racial inequity, people who have suffered a recent loss or series of losses, people with family instability or poor social supports. There's a growing body of evidence, however, that says that the number one predictor of resilience is meaningful relationships, connections to people we care about. Now we are working collaboratively with community-based organizations to develop a program to support long-term emotional and physical recovery for our community. We have started a 3-year resiliency collaborative with 12 community partners that will train 300 people to facilitate groups in mindfulness-based self-care practices where they work, live, and play, with the goal of reaching 8,000 of our most vulnerable community members. Our goal is to build the long-term capacity for resilience and create a self-healing community. Every emergency will be different. It's likely that in a big earthquake there will be limited or no cell phone coverage, no telephone service, maybe no water or electricity. Preparation for a disaster at this level is truly challenging. Having an emergency plan is important. Having an understanding of the roles that will need to be played, the resources that will need to be deployed is critical. However, I think the most important preparation we did as an organization was work we had done a year before in preparation for our branding initiative. We had just spent a year discovering who we really are as an organization, what our values are, what our culture is, what our organizational personality is, and articulating those to all the staff. Our internal rallying cry is united in heart, health, and justice. This was our anchor throughout the disaster. We knew we were innovative and courageous and nimble, and that we would be here for our community and each other no matter what. You do find out what your real values are in an emergency. No time to debate or analyze. And as they say, culture eats strategy for lunch. But we knew our culture, and we could execute our strategy. We never thought for a minute about laying people off. We were closed for one day. Taking care of patients was the overwhelming motivation. We deployed providers throughout the county, regardless of whether or not we could bill or get paid. We took care of everyone. There is no perfect preparation, but it's very clear to me that in addition to emergency preparedness, the years of investment in developing community partners and relationships, knowing the people in your organization deeply, and living our values were critical to our emergency response. I am deeply grateful for the most phenomenal team of leaders and staff at Santa Rosa Community Health, many of whom are here this morning. It was a huge and exhausting endeavor that took perseverance, and most importantly, it took love to accomplish what we did. Love for our patients, our community, and each other. It takes patience and understanding in the midst of moving at breakneck speed. It takes making space for our moments of meltdown as well as celebrating small and large accomplishments. Now, little by little, we are finding the new normal, the new rhythms. We have new staff and new locations, and we're rebuilding on the inside as well as the out. Everything isn't perfect, but we are resilient. We are springing back, like bamboo in the wind, changed forever but still strong. I leave you with this poem. Perhaps it is fitting for our world today in many ways. Do not be dismayed by the brokenness of the world. All things break, and all things can be mended. Not with time, as they say, but with intention. So go. Love intentionally, extravagantly, unconditionally. The broken world waits in darkness for the light that is you. Thank you. Where do I go now? Thank you.